Good afternoon, everybody. I'm delighted to talk to you today and thank you for the invitation. This project was developed in 2012 due to a number of reasons, but the main ones are: in 2003, the National Council of Europe highlighted that access to palliative care services should be based on need and must not be influenced by disease type, geographical location, socio-economic status or other such factors. And as you can see, there have been a number of reports that influence palliative care service development and delivery in Ireland. One of the more significant reports in 2008, about integrating palliative care into disease management frameworks, advocated extending access to specialist palliative care services to patients with a non-cancer diagnosis. In St Francis Hospice, we were involved in the Action Research Project with Karen and the team in the matter, and this highlighted the need to develop the service in a hospice daycare setting. And additionally, with the opening of our second hospice in Blanchardstown and the expansion of our daycare services, we had the capacity in our service to embark on this initiative. For those of you not familiar with St Francis Hospice, historically our patient cohort had a diagnosis of cancer, motor neuron disease or AIDS, and our percentage of patients with a non-malignant diagnosis was low. As you can see, when the project started in 2012, it was less than 10%. Yet another cancer and heart failure trajectory. We've seen a few of these this morning in different presentations, and although patients with cancer and heart failure can have similar symptomology, we will see here from these two slides that the trajectories are quite different. The heart failure is interspersed with periods of decline and improvement, and a sudden decline at the end. Whereas with cancer, patients may steadily decline with a sudden decline at the end. And all of this impacts on the care they receive. This difference and unpredictability was a challenge for staff in terms of prognostication and planning care, and a number of patients died before they could attend the programme. So how did we do it? In terms of development, we initially worked with the cardiology team in the matter, and then expanded the programme to Connolly and Beaumont Hospital. Change can be difficult, and in developing this programme, it was important to meet the staff involved. We visited the hospital to meet the team, and the hospital staff came to the hospice to see what we had to offer. And this was really useful because they could then explain to their patients in clinic who they'd meet, what they'd see, what would happen. Education sessions were organised in the hospice to upskill us on heart failure, the advances, the devices. All of this was new to us. And a working group was formed to develop the programme. The aims of the programme are listed here and are fairly self-explanatory. However, the benefit the patients received depended on their disease burden and their capacity to participate in the programme. As with any type of service development, decisions need to be made as to who to include and exclude. This was our inclusion criteria: New York Heart Association Class 3 and 4, living within our catchment area of North Dublin City and County, and patient consent. This is our exclusion criteria. Again, cognitive impairment, primarily social need, outside the area. And as the programme progressed, we added if the person had completed the programme within the last year, as so many people wanted to repeat it. And on reflection, it turned out to be quite a satisfactory overall criteria. These are the assessment tools we used, and they're fairly standard and familiar to people. This was the programme pathway, and it proved to be an effective pathway. Referrals are made from the hospital teams using the National Specialist Palliative Care Referral Form. We asked for some extra information to be included on the referral form, such as resuscitation status and whether a device was implanted or not. The staff in the Hospice Daycare Centre made the initial phone call to patients to invite them to attend the hospice for MDT assessment 1 to 2 weeks before the programme started. And what surprised us, and I suppose in reflection we should have thought of it, some patients were really shocked to receive a phone call from the hospice. Even though it had been discussed with them in clinic, they were very surprised to hear from us. Some thought they had cancer and no one had told them. and we were ringing to break the news to them that the hospice was coming to see them because they had cancer. So we very quickly changed our practice, and when we rang, we explained, we're from the hospice, but we're here to help with your heart failure. When patients attended for their initial assessment, they met members of the multidisciplinary team and were shown around. They were given an outline of the day and the programme content. And this really took the initial fear and anxiety out of coming to a hospice. Lots of people worried about what would it be like. Would there be very sick people there? How would it be? It also allowed for early identification of issues or problems, and we could make appropriate referrals there, whether to other members of the MDT in the hospice or to community or primary care teams such as public health nurse or GP. As you can see from this slide, there was quite a lot of activity during the day, and I'll talk a little bit more about the different team interventions. We were very conscious of patients' ability to participate. This group of patients were very tired, they were very dyspneic, and we adjusted the activities accordingly. And proactive discharge planning started at the very beginning of the programme. Patients knew this was an 8-week programme. They knew there was an end date in sight. And transport was provided by our team of volunteers. And this was really a key component to the success of the programme, because we were able to bring people in from home and bring them home again. In relation to team interventions, nursing coordinated the overall care, the programme of care for these patients. Nursing assessments included identification and management of symptoms such as dyspnea, pain, constipation, fatigue and anxiety. A lot of the symptoms that we found didn't relate to the heart failure, but had an impact on the patient's quality of life, such as constipation, such as anorexia, cachexia, symptoms that had been mentioned earlier. And by making very small adjustments to medication, we were able to resolve these symptoms, which improved patients' overall quality of life. We looked at medication management, something as simple as putting medications into a blister pack, so patients were taking their medications regularly. A psychosocial support and advanced care planning formed a key component of the role as well. Some patients really welcomed the opportunity to talk about their concerns, about their illness, and the limitations it has imposed on them and their family. Some would say they're too short of breath to play with the grandchildren or to attend family events. They really felt they were missing out on life. Also, being in the hospice created an environment for these conversations to happen around future care planning, around death and dying, the where, the when, the how, the who would be there, what would I expect, what might happen. And practical issues were addressed, including liaising with community services and relevant hospital teams. We also included the family in the programme, and some family members came for the initial assessment to see the place and to meet the team. But during the programme we provided telephone support, looking at the family's experience, their concerns, their worries, planning practical issues. And support was offered through the social work department and chaplaincy service as well. From a physiotherapy perspective, a weekly 45-minute group exercise programme was provided, as detailed in the slide. Heart rate was measured in a range of 40 to 50%, calculated on completion of the 6-minute walk test. And patients were taught the Borg rate of perceived exertion scale and were exercised only in the range of 3 to 4. Patients were closely monitored, vital signs were recorded, and thankfully no adverse events occurred. As you can see from this slide, the Occupational Therapy group department provided group and individual activities. Activities of daily living retraining included compensatory strategies, modified techniques and adaptive approaches. And equipment was given to assist with personal and domestic ADLs. Complementary therapy, this was a real favourite. The team facilitated reflexology or aromatherapy massage, and all the patients loved this and really look forward to their treatment. The blend of oils used in treatment were customised and were provided for patients to use at home. In the hospice, the team make up their own blend of aromatherapy oils depending on the patient's symptoms, and it's often very useful for things like night sweats, itch, arthritic pains, and the patients found these very useful. And patients reported a reduction in their stress, anxiety and physical tension. In terms of social work and chaplaincy input, patients were referred as required. Some of the patients had issues which related to bereavement support. Many of them had a recent bereavement and were grieving, and some actually said they felt their heart was broken. They welcomed the opportunity to talk about this loss and the impact this had on their lives. Some spoke of the loneliness of going through their illness without their spouse who had died. They didn't think they'd be alone in their own old age or facing serious illness on their own. Some had issues in caring for a family member with ill health or dementia. They were the actual carer, even though they had their own issues. Referrals were made to community services for ongoing support after the programme, and practical issues were addressed, such as financial concerns. In terms of numbers, since the programme began in 2012, we've received 73 referrals. 7 patients died prior to commencement, and 8 patients declined. It wasn't for them. They didn't want to come to the hospice. We have 7 patients on the waiting list for the next programme. So 51 patients attended and started the programme, and 41 completed the programme. The 10 who didn't complete, the reasons are listed there. 3 died, 4 became too unwell to continue, 1 was admitted to the inpatient unit in Raheny, and 2 was patient preference, and that related to distance. The death of 3 patients during the programme started conversations with the remaining patients. They didn't expect one of their group to die. This was a surprise to them, and it allowed these conversations to happen. As you can see from the graph, there was an overall improvement in the patient's functional ability. The purple colour indicates improvement, the blue shows no change, and the teal shows a disimprovement. In relation to the 6-minute walk test, 3 patients disimproved. This was due to 1 patient had gout, another diabetic foot ulcer, and some arthritic knee problems. Interesting to note, there is a disimprovement in the POS and the HADS. What we found was as patients got to know us over the course of the programme, they began to feel more comfortable to disclose the issues and concerns they had. They felt able to talk about the family issues that were maybe too personal or private to talk about at the beginning of the programme. But the Minnesota shows an overall improvement. So we were very happy with the results. As this was a new project, it was important to get feedback from the patients' perspectives and to see what their experience had been. So we decided to conduct patient interviews 2 weeks after completing the programme. All patients who attended the first 2 programmes were invited to attend for interview. So 10 patients were interviewed, with the interviews lasting from 10 to 50 minutes, and the interviewer was not known to the patients. He hadn't been part of the programme. So some of the things we hoped to learn were, did it make any difference to them? Was there anything we needed to change? And what to consider for future developments of programmes in the hospice daycare setting. There's quite a bit on this slide, but as you can see, a number of themes were generated from the interviews. Some patients said it was a surprise to be referred to the hospice. Patients spoke of the move from the security and familiarity of their hospital team, who they had great confidence in, to a new team in the hospice, and they wondered how that would be for them. As the programme was located in the hospice, this gave rise to conversations about the future, their illness and the prognosis, and this was uncomfortable at times for them. For some patients, it was a challenge to physically push themselves, but there was a sense of achievement when they did, and a realisation that they could actually do more than they thought. And at the end, when we did the 6-minute walk test again, there was great competition between some of the patients. What was your score? Did you improve? Well, I did better than you. Moving on then, towards week 5 and 6 of the programme, people started to realise it was starting to come to an end, and they began to think about it and how would that be for them. Some wanted to stay. They really enjoyed the interventions, the support, the monitoring, and the company. So many people felt socially isolated and lonely at home. It was lovely to meet somebody else with heart failure. People would have said in clinic, you see somebody sitting outside and then they're gone when you come out, but to actually sit and talk to somebody, well, do you have this, or what are you on, or that worked for me, they found the peer support really helpful. Some patients recognised the progress they had made and felt better enabled to cope with life again. They felt re-energised and their mindset was different. They felt more positive about coping with their illness. And others spoke about knowing they could avail of palliative care again in the future if they needed it. These are just 2 comments from patients. It knocked me at first because the hospice is for cancer and I thought I had it. I find it hard to breathe. You can see that for yourself. but I didn't realise I could do so much. I'm glad I had it. It was the right thing to do and has helped a lot. So we can see from this slide that the programme was successful. There was an improvement in outcome measures, and patients had a desire for a re-referral, and 4 or 5 patients have actually repeated the programme since then. And we note that there's been an increase in the percentage of patients with a non-malignant diagnosis availing of the hospice care. It's gone from 12%, less than 10% in 2012 to 21% last year. So with every new initiative there are challenges, and from a patient perspective, some of the challenges were, as already mentioned, some thought they had cancer and no one had told them. Others worried about leaving the security of the hospital team. We explained we weren't replacing the team, but we were an additional layer of support to their team and primary care services. There was also a sense of them and us. When the patients with heart failure came into the service and met the patients that had a cancer diagnosis, they were often surprised to see younger patients there who were often sicker than them. And some patients mentioned, God, I'm not as bad as that poor man sitting over there. I'm not as bad as I thought. So for the first week or two, there was a little bit of them and us, but very quickly patients got to know each other, and there was great support and banter between them all. And when the group of patients finished, so 6 or 7 patients might have finished on week 8 on that particular day, the patients with cancer caused some anxiety for them. Were they being discharged? Was something different for them as well? So we quickly learned and tried to meet these challenges as much as possible. Some patients felt reassured to know they've been to the hospice. They would have seen the inpatient unit if they wanted. They know they could come here to die if they weren't able to manage at home. There was a place for them to go, someone to care for them. From an organisational point of view, the programme ran as described for 2 years. But since December 2014, the physiotherapy input was withdrawn due to staffing. And since July of this year, occupational therapy input has been withdrawn due to staff shortages. So in conclusion, our evidence suggests that the aim of the programme has been met. The programme will continue without the allied health professional involvement for the foreseeable future. Nursing, social work, chaplaincy and complementary therapy will continue to provide input to the patients. And our aim is to return to a full level of service in the future, depending on allocation of additional resources. That's it. Thank you.